Welcome to the deep dive. Today, we're shifting gears a bit. We're not focusing just on, the chemistry of medications.
Right.
Instead, we're looking at all the critical stuff around the drugs, the culture, the law, the ethics, everything that really impacts how safe and effective that therapy is for you, the actual patient.
Exactly. Our source material really takes us there, looking at pharmacology, but framed by actual patient care. So the mission today is to pull out those key insights.
Okay.
Insights that show giving medication isn't simple. It's it's dynamic. It involves understanding genetics, following strict legal rules, and really sticking to ethical principles,
Mm-hmm.
especially for nurses right on the front lines.
Okay, let's unpack this then. So, what we're saying is effective drug therapy isn't just about knowing how the drug works. You absolutely have to understand the patient's whole background and the legal lines you have to operate within.
Precisely.
So, we should probably start with the patient, right? That's where care always begins.
Mm-hmm.
And our sources, they immediately point out this major shift happening in the U.S. demographics.
Yeah, it's significant. Projections show over half of Americans belonging to a minority group by 2044. Huge increases in Hispanic and Asian populations, for example.
Which means that old idea of a standard dose for everyone, well, it's becoming pretty outdated, maybe even dangerous.
It forces us to look at specialized fields like ethnopharmacology. That's the study of how someone's ethnicity affects drug response absorption, metabolism, the whole pharmacokinetic journey.
Okay.
And then there's pharmacogenomics, which gets even more specific. It looks at how your inherited genetic traits directly influence how you respond to a drug.
And the term that kind of ties all these factors together, age, diet, culture, genetics, is drug polymorphism, right?
That's the one, drug polymorphism. It basically means variation in drug response is expected. It's the norm.
And this is where it gets really interesting because it's not just cultural habits influencing things, it's actual, microscopic genetic differences.
Absolutely. Take metabolic speed. We see huge genetic variations in liver enzymes. So you have people categorized as slow acetylators.
Okay, what does that mean practically?
Well, it includes many patients of European and African descent. They metabolize certain drugs like isoniazid for TB much more slowly. So they need lower doses. Otherwise, the drug builds up potentially to toxic levels.
Right. Okay. And the opposite.
The opposite is rapid acetylators. You see this often in some patients of Japanese descent. They chew through certain drugs so fast that a standard dose might do almost nothing. They often need a significantly higher dose to get the therapeutic effect.
Wow. So it really varies.
It really does. And it often comes down to variations in these cytochrome P450 enzymes. They're key liver enzymes for metabolism, but the levels aren't the same across ethnic groups.
So how does that play out?
Well, the sources mention that some Asian patients genetically are poor metabolizers. They might need much lower doses of common drugs. But then you might have some white patients who are ultra-rapid metabolizers and need surprisingly high doses of the same drug.
So if I'm a nurse or a doctor and I just give everyone the same dose without thinking about this, I could be accidentally overdosing one person and underdosing the next, just based on their genetic background.
That's the risk. It highlights why personalized medicine isn't just a buzzword. It's essential.
Do we have specific examples, like for common conditions?
Yeah, and they really drive the point home. For hypertension, Black patients often respond better to thiazide diuretics or calcium channel blockers like diltiazem,
Okay.
but they tend to respond less well to beta blockers or ACE inhibitors compared to, say, white patients.
Interesting.
And it's crucial in mental health, too. Asian and Hispanic patients often need lower doses of antipsychotics and anti-anxiety meds. The source mentions Chinese patients needing less haloperidol, Japanese patients needing less anti-manic medication.
Which brings us back to the nursing process.
Exactly. A thorough cultural assessment is non-negotiable before giving medication. You need to ask about language, sure, but also about herbal remedies, folk medicine like maybe African Americans using herbal teas or Hispanic patients using hot-cold remedies.
Right, because those could interact.
Definitely. Or religious practices Christian scientists might avoid meds altogether. Even dietary habits can affect those P450 enzymes. It all has to be part of the initial assessment. So if genetics explain the why of different responses, the law explains the how of keeping things safe. And what's really striking is that almost every major piece of U.S. drug law came about because something went terribly wrong.
Yeah, these weren't small errors. We're talking major tragedies, like the sulfanilamide disaster in 1937.
Right, a drug put out with basically no toxicity testing. Over 100 people died, mostly children.
Horrifying. And that led directly to the 1938 Federal Food, Drug, and Cosmetic Act.
It did. That act forced manufacturers for the first time to prove their drugs were safe before marketing them.
And then came thalidomide.
Ugh, yes. In the 40s through the early 60s, a sedative used in Europe caused devastating birth defects. That spurred the 1962 Kefauver-Harris amendments here in the U.S.
And those required?
Not just safety, but also efficacy. The drug had to actually work for its intended purpose and be safe. A huge step forward.
So these events really shaped the FDA and the DEA's roles.
Absolutely. And central to controlling potentially dangerous drugs is the Controlled Substance Act of 1970. This set of the 5 schedules, CI through CV.
Let's break that down a bit. It's based on abuse potential and medical use, right?
Correct. CI is the highest risk. Think heroin, LSD. High potential for abuse, and importantly, no currently accepted medical use and treatment in the United States. They can only be used in very tightly controlled research.
Okay. Then CI. Still high abuse potential.
Very high abuse potential, yes. But these do have accepted medical uses. This is where you find drugs like morphine, hydrocodone, oxycodone, Adderall.
And the key difference for handling them.
Big difference. CFAR drugs usually require a written prescription, no refills allowed. Very strict controls on ordering and storage because of the high risk.
Got it. And then the schedules go down from there.
Right. CTHOR, CIV, CV have progressively lower abuse potential. CV includes things like cough syrups with a tiny bit of codeine, much lower risk, fewer restrictions.
And alongside controlling the drugs themselves, there's controlling patient information. That's IIP, right?
Yes, IPA, the Health Insurance Portability and Accountability Act of 1996. Crucial for protecting patient privacy. Your health conditions, treatments, even billing info that's protected health information, or PHI. Strict rules about who can see it and share it.
Keeps everything confidential.
Supposed to, yes. Serious penalties for violations.
Okay, so that covers existing drugs. What about new ones? The investigational new drug process, the IND.
Right. Before a drug candidate even gets near a human, it goes through preclinical testing. That means lab studies in vitro, on cells and tissues, and then animal studies, looking for early signs of toxicity.
Trying to catch problems early.
Exactly. If it looks promising and relatively safe there, then it can move to human testing, but not before getting informed consent.
And that's more than just signing a form.
Oh, absolutely. It has to be a thorough explanation. Purpose of the study, potential risks, potential benefits, alternatives, everything. And it must be completely voluntary. The person has to know they can withdraw at any time for any reason without it affecting their regular medical care. That's fundamental patient autonomy.
Makes sense. So then come the clinical phases.
Yep, 4 phases. Phase I is usually small numbers, maybe 20 to 80 healthy volunteers. The main goal here is to check safety in humans, figure out the best dosage range, and see how the body processes the drug, the pharmacokinetics.
Healthy people first.
Yeah.
Then phase 2.
Phase 2. Now we move to a slightly larger group, maybe 100 to 300, but these are volunteers who have the disease or condition the drug is meant to treat.
Ah, okay. Testing if it actually works.
Yes. Testing effectiveness, monitoring for side effects, and refining that dosage range further.
And phase 3, that's the big one.
That's the big one. Phase 3. Much larger numbers, often thousands of patients across multiple centers. This is where you often see placebo controls and double-blind studies.
Explain double-blind again.
Sure. It means neither the patient nor the researcher, the investigator administering the treatment, knows who is getting the actual drug and who is getting the placebo, the inactive substance.
Why do that?
To eliminate bias. If the patient knows they're getting the real drug, they might feel better just because they expect to. If the researcher knows, they might subtly influence the results or interpret ambiguous outcomes differently. Double blinding keeps it objective.
Gotcha. So phase 3 really nails down effectiveness, safety, and the final dosage.
That's the goal. If phase 3 results are positive, the company can apply to the FDA for approval to market the drug.
And phase 4, isn't that after it's already approved?
It is. Phase 4 is post-marketing surveillance. The company often continues to study the drug, sometimes voluntarily, sometimes required by the FDA. They gather more data on its effects, both good and bad, in the general population, often for at least 2 years. Sometimes rare side effects only show up once millions of people are using it.
And if serious problems do show up later,
That's when the FDA might step in with warnings or recalls. The most serious warning is the black box warning.
well, one with a literal black box around it on the label.
That's the one. It means significant risks, possibly life-threatening side effects, have been associated with the drug. Now, importantly, the drug can usually still be prescribed.
Oh, okay. It's not necessarily pulled from the market.
Not always. But the prescriber must be aware of that specific risk, weigh it against the benefits for that patient, and warn the patient about it. It's a serious alert. Recalls are different. Class 1 is the most serious, where use could cause death or serious health problems. Class 2 is for temporary or reversible issues, and Class 3 is the least severe, unlikely to cause significant harm.
Yeah.
So we've covered the patient's individual response, the legal framework. Now we shift to the ethical side. And what's really key here is how these ethical principles guide nurses, especially when facing tricky decisions about medications, even when the law seems clear.
Right, because sometimes the legally correct thing might not feel like the ethically right thing.
It can get complex. The sources emphasize these core ethical principles, like autonomy, the patient's right to make their own decisions. That underpins informed consent, doesn't it?
Definitely. And beneficence.
Beneficence is actively doing good, always asking, how is this action best serving the patient? Then there's his counterpart, nonmaleficence. Do no harm. The absolute fundamental duty in healthcare. Especially critical when giving drugs that inherently carry risks.
Makes sense. What else?
Veracity. That's the duty to tell the truth. Really important when explaining medications, potential side effects, or, dealing with investigational drugs or protocols.
And that duty to tell the truth. That must clash sometimes with placebos, right?
It definitely can.
Yeah.
We just talked about how placebos are vital for good research, especially in those double-blind phase 3 trials. But using a placebo in regular clinical practice, just to, say, appease a patient asking for pain meds when maybe the doctor thinks they don't need them.
That sounds ethically murky.
It generally is. Outside of a formal approved research study where the patient understands placebos might be involved, using one without telling the patient is usually seen as unethical. It's deceitful, it breaks that trust, and it violates veracity.
So what should a nurse do if they get an order for a placebo in a non-research setting?
The nurse has an ethical and often legal obligation to question that order. They need clarification. Is this part of a study? Has the patient consented to potentially receiving a placebo? If not, administering it could be problematic. Ethical practice demands transparency.
Good to know. What about the other principles?
There's also justice being fair and equal in distributing care and resources, and confidentiality, respecting private information, which obviously ties back into HIPAA.
So these principles, along with the law, define the standard of care.
Exactly. And that standard is legally enforced through state nurse practice acts, or NPAs. These laws define what a nurse can and cannot do, their scope of practice, the expected level of care.
And if a nurse falls below that standard?
That's where malpractice or negligence comes in. Negligence is basically failing to act as a reasonable and prudent nurse would under similar circumstances.
And how does that relate specifically to giving medications?
Oh, and anyways, the sources point out key areas of liability. Failure to assess or evaluate, like not noticing if a patient's condition changes significantly after getting a drug, or not checking vital signs before giving a heart medication.
Okay.
Failure to ensure safety. That could be using the wrong route, like giving an IV drug intramuscularly, or failing to check for allergies before giving a drug. Medication errors are a huge category. Wrong drug, wrong dose, wrong time, wrong patient.
The rights of medication administration?
The fundamental rights. Violating them can lead to liability. And finally, fraud, deliberately falsifying records, like charting that a drug was given when it wasn't. Following the NPA and documenting accurately are the nurse's best protection. #outro.
Okay, so wrapping this up, we've really covered a lot of ground around pharmacology that isn't just the drug itself. 3 big takeaways seem to stand out. First, drug response is super individual, right? Culture, genetics, that polymorphism idea driven by enzymes like P450 means you have to do a thorough patient assessment.
Absolutely. One size definitely does not fit all.
Second, the legal side. The FDA, the Controlled Substances Act, the whole clinical trial process. It's all built on hard lessons learned from past tragedies, all aimed at ensuring drugs are both effective and safe for the public.
Safety and efficacy mandated by law.
And third, the ethics and professional standards. Principles like autonomy, doing no harm, telling the truth, combined with the Nurse Practice Acts. These define how healthcare professionals, especially nurses, must act to provide safe, ethical medication administration. Honesty and patient advocacy are key.
Well put. And thinking about that first point, the variations in metabolism, those P450 enzymes we discussed, makes you wonder, doesn't it?
How so?
Well, we talked about how different ethnic groups can have vastly different enzyme activity, making standardized dosing tricky. So here's something to think about. As technology gets better and faster at mapping an individual's specific genetic profile,
Hmm.
what does the future of pharmacology look like? How close are we, really, to truly personalized medication, where the dose is tailored not just to a group, but to you, the single patient, for every single drug?
Hmm. A fascinating question about where this is all heading. Truly personalized dosing. That would be a game changer.
It really would.
Well, thank you for sharing the insights from the sources and diving deep with us today into this really crucial landscape surrounding pharmacology.
My pleasure.
We hope this encourages all of you listening to keep exploring these vital non-drug factors that really shape patient care and safety. Thanks for joining us on the deep dive.